It's a pleasure to be with you. The title of this session is Organization and Financing of Public Health, Part 2, Federalism and Public Health. There are no disclosures for this presentation. Objectives include review the history of federalism and its impact on the U.S. public health system, review the roles of federal and state public health in the United States, review the concepts of home rule and Dillon's rule, review the advantages and disadvantages of federal public health decentralization, review the recommendations of the IOM to deal with federal decentralization, review public health values, core functions, and essential services. The governmental public health system in the United States is of 4 parts, comprised of several federal departments and agencies, sovereign tribal departments, at least one state-level department for every state and territory in the country, and approximately 2,800 local health agencies. Thousands of public health workers staff these agencies, though unfortunately, the public health workforce has been shrinking in recent years. From 2012 to 2019, the state health workforce decreased by almost 10%, from 101,619 full-time equivalents FTEs to 91,540 FTEs. One of the general principles of the U.S. Constitution is that citizens should be protected from oppressive government systems. This makes sense since the Constitution was written following the Revolutionary War to free the colonies from the oppression of the British Crown. This general principle resulted in language limiting the scope and power of government. The U.S. public health system is decentralized due to the adoption of federalism, which limits federal power. Federalism means that sovereign power is shared between the federal government and the states, with certain powers delegated to the federal government exclusively, certain powers retained by the states exclusively, and some powers held by both the federal and state governments. The 10th Amendment to the Constitution states that the powers not delegated to the United States, federal government, by the Constitution are reserved to the states, meaning that all the powers not expressly granted to the federal government are retained by the states. For example, since the Constitution doesn't specifically give the federal government the authority to protect and promote the public's health, that authority and power is primarily held by the states. The Constitution's Supremacy Clause clearly defines the concept of federal primacy, which states that the federal Constitution, statutes, and treaties are the supreme law of the land, and thus preempt state laws that conflict with them. Yet the Constitution deliberately limited the powers of the federal government to prevent federal overreach. The Constitution provides the federal government with the power to tax and spend and to regulate interstate commerce. So the public health activities of the federal government generally derive from these powers. One power not specified in the Constitution is police power, the power to regulate and enforce public health issues. Since police powers are not specified in the Constitution, those powers, including public health police powers, remain with the states. A Supreme Court decision in 1849 regarding the authority to quarantine ship passengers clearly stated, "The states of this union may, in the exercise of their police powers, pass quarantine and health laws, reaffirming the intent of the Constitution that states have primary authority for public health in the United States. So states regulate public health through their police powers. The U.S. government public health system is a highly complex system of discrete, often independent, decentralized, and varied departments and agencies. The federal government public health system in the United States is not just decentralized, but highly decentralized, since the federal government has little direct control over state public health matters. Even though the federal public health system is highly decentralized, state and local public health express a variety of governance models, including centralized, decentralized, mixed, or shared systems. States are responsible for the design of their own public health systems, and in most circumstances, states delegate authority to local political units, including local boards of health in cities, towns, and counties, to develop and implement their own public health policies. So instead of exercising authority directly over health matters in the United States, the federal government's role is primarily one of influence through persuasion and recommendations based on research and/or through financial incentives via federal grant requirements. Let's discuss Home Rule and Dillon's rule, which demonstrates the decentralization of federal public health in the United States, providing states with significant freedom to delegate public health authority within their jurisdictions. As you can see in this map, all 50 states express various forms of home rule, limited home rule, Dillon's rule, or both. Home rule means that a state's local governments have the authority to exercise powers of governance, with that authority either expressly delegated by the state or implicitly allowed when not specifically denied by the state. Dillon's rule means that a state's local government only has the authority to exercise powers of governance if expressly delegated by the state. Each state defines for itself what powers it will grant to local governments. Let's consider the advantages and disadvantages of the decentralization of public health in the United States. Advantages include priorities are more aligned with local needs. Programs are more informed and responsive. Better use of resources. More accountability to local communities and stakeholders. Builds local capacity. Improves access to health services. Enhances community participation in decision-making. Is better able to fulfill local needs, and provides better health outcomes. Disadvantages include there can be less coordination of activities nationally and within states and regions. Limited resources, including sources of revenue, especially for small or disparate populations. Less institutional capacity for health programs. Excessive workload for a limited workforce that may lead to workforce burnout and morale issues. Limited service capacity. Poor management of resources due to limited management expertise and training. And no central public health authority with nationwide reach. Though there are many advantages to the decentralization of public health, the ability of the U.S. public health system to deliver services has been criticized. The 1988 Institute of Medicine IOM report, The Future of Public Health, stated, there has been a growing sense that public health as a profession, as a governmental activity, and as a commitment of society is neither clearly defined adequately supported nor fully understood. The nation, in overlooking the public health system, was unable to fully achieve its public health goals. Though that report was from 1988, it still applies today. So how did the U.S. overlook the public health system and fail to meet its public health goals? It seems that federal decentralization may be part of the reason. There is no central public health authority in the United States with nationwide reach. No entity or agency assigned the responsibility for operating a national public health system. Because public health regulations and services are implemented primarily at the state and local level, public health goals represent local political jurisdictions and communities, each with their own health problems, concerns, priorities, political systems, resources, organizations, values, and solutions. So public health systems vary greatly from community to community. While this characteristic may enhance local control, appropriateness, and flexibility of local agencies to meet the needs of their population, it also leads to fragmentation, confusion about public health roles and responsibilities, uneven distribution and quality of services provided, and less coordination between jurisdictions in response to health problems. The IOM concluded that viewed from a national perspective, the national public health system is a scene of tremendous variety and disarray as different communities work out different solutions to public health problems. The IOM did not conclude that the structure of the U.S. public health system was inherently flawed, but acknowledged that states have primary authority over public health matters, that local health departments provide most public health services, and that the federal government has the resources to facilitate improvement of the public health infrastructure. It emphasized that all communities should be covered by a public health system, and concluded that this was only possible through local public health as part of an organized nationwide system of state-level agencies. Rather than propose a reorganization of the public health system, the IOM concentrated on the enterprise of public health and identified three core functions that should be adopted and performed by public health agencies at all levels of government. For a few minutes, let's review the 5 values, 3 core functions, and 10 essential services of public health. The American Public Health Association has identified 5 key values that represent public health practice. These values have propelled public health for nearly 150 years and continue to form the skeletal backbone of the field. Those 5 values include 1. Community. We believe we have greater potential for impact when we create community to solve problems, share new ideas, and explore different perspectives. Community engagement skills and competencies are essential for public health practice. 2. Science and evidence-based decision-making. The best policies and practices are ones based on research, with evidence that demonstrates effectiveness. The best innovations come from testing new ideas and approaches. Not all best practices have been identified. There will always be a need for innovation. This is especially true for rural areas and special population groups. 3. Health equity. We believe in conditions that give everyone the opportunity to reach their best health. This requires valuing all individuals and populations equally. It means addressing inequities in places where people are born, grow, live, work, learn, and age. When will we know we have succeeded? When health disparities are eliminated. 4. Prevention and wellness. Preventing disease and injury, mitigating the impact of disasters through preparedness, and ensuring an environment where the healthy choice is the easy choice are worthwhile investments that lead to an overall improved human condition. 5. Real progress in improving health. Our effort must result in forward movement in health impact. Sometimes that is a leap forward. Other times it's small steps. But always it is real progress. These are a good set of public health values upon which to build a strong, equitable, effective public health system and practice. This slide lists the 3 core public health functions, including 1. The assessment and monitoring of the health of communities and populations at risk to identify health problems and priorities. To accomplish this function, enhanced collaboration and partnership between academic institutions and public health departments is required. Health departments are generally data rich, but have limited capacity to research and analyze that data. On the other hand, academic institutions have that research and analysis capability, but often limited access to data. A marriage between academia and practice is beneficial to both parties. 2. The formulation of public policies designed to solve identified local and national health problems and priorities. Public health professionals must position themselves to appropriately advocate with policymakers. 3. To assure that all populations have access to appropriate and cost-effective care, including health promotion, disease prevention services, population and community health programs, and evaluation of the effectiveness of those services and programs. To accomplish this function, enhanced collaboration and partnership with a variety of stakeholders, including healthcare systems, is essential. Public health can't provide the resources necessary to plug all access gaps to services and programs. The IOM acknowledged that implementation of the core functions would provide some standardization of public health practice, but would also necessarily vary from place to place. The specific actions appropriate to strengthen public health will vary from area to area and must blend professional knowledge with community values. In 1994, the Department of Health and Human Services, DHHS, convened a committee titled the Public Health Functions Steering Committee, chaired by the U.S. Surgeon General, with representatives from all major public health constituencies, including the American Public Health Association, APHA, the Association of Schools and Programs of Public Health, ASPPH, the Association of State and Territorial Health Officials, ASTO, the Environmental Council of the States, ECS, the National Association of County and City Health Officials, NACHO, the National Association of State Alcohol and Drug Abuse Directors, the National Association of State Mental Health Program Directors, the Public Health Foundation, PHF, and the divisions of DHHS constituting the U.S. Public Health Service. The committee released a consensus statement titled Public Health in America, which stated the vision, mission, purposes, and essential functions of public health in the United States. According to the statement, public health 1. Prevents epidemics and the spread of disease. 2. Protects against environmental hazards. 3. Prevents injuries. 4. Promotes and encourages healthy behaviors. 5. responds to disasters, and assists communities in recovery. 6. Assures the quality and accessibility of health services. This is the original 1994 list of 10 essential services. 1. Monitor health status to identify and solve community health problems. 2. Diagnose and investigate health problems and health hazards in the community. 3. Inform, educate, and empower people about health issues. 4. Mobilize community partnerships and action to identify and solve health problems. 5. Develop policies and plans that support individual and community health efforts. 6. Enforce laws and regulations that protect health and ensure safety. 7. Link people to needed personal health services and assure the provision of health care when otherwise unavailable. 8. Assure competent public and personal health care workforce. 9. Evaluate effectiveness, accessibility, and quality of personal and population-based health services. 10. Research for new insights and innovative solutions to health problems. In 2020, the Public Health National Center for Innovations and the de Beaumont Foundation revised the original 10 essential services to, as stated by the CDC, bring the framework in line with current and future public health practice. The revised essential public health services include 1. Assess and monitor population health status, factors that influence health and community needs and assets. 2. Investigate, diagnose, and address health problems and hazards affecting the population. 3. Communicate effectively to inform and educate people about health factors that influence it and how to improve it. 4. Strengthen, support, and mobilize communities and partnerships to improve health. 5. Create, champion, and implement policies, plans, and laws that impact health. 6. Utilize legal and regulatory actions designed to improve and protect the public's health. 7. Assure an effective system that enables equitable access to the individual services and care needed to be healthy. 8. Build and support a diverse and skilled public health workforce. 9. Improve and innovate public health functions through ongoing evaluation, research, and continuous quality improvement. 10. Build and maintain a strong organizational infrastructure for public health. The 10 essential services translate the 3 core functions identified by the IOM into a more specific set of activities. These essential services embody the protections and services that every citizen has the right to expect and every government has the obligation to assure. No matter what the unique features of any single community, the concept of the 10 essential services recognizes that every community needs a robust and reliable agency infrastructure. The 10 essential public health services provide a framework for public health to protect and promote the health of all people in all communities. To achieve equity, the essential public health services actively promote policies, systems, and overall community conditions that enable optimal health for all and seek to remove systemic and structural barriers that have resulted in health inequities. Such barriers include poverty, racism, gender discrimination, ableism, and other forms of oppression. Everyone should have a fair and just opportunity to achieve optimal health and well-being. In summary, the U.S. public health system is decentralized, due to the adoption of federalism, which limits federal power. The authority to protect and promote the public's health is primarily held by the states. The federal government's role in public health is primarily one of influence through persuasion and financial incentives. Partly due to federalism, the U.S. was unable to fully achieve its public health goals. The 10 essential services translate the 3 core functions identified by the IOM into a more specific set of activities to help standardize public health in the United States.